Introduce Dr. Bernard Suter. He's an assistant professor in pediatric neurology at Baylor College of Medicine, Texas Children's Hospital. He was born and raised in Bonn, Germany, and there he went to medical school in the 90s, obtaining a Doctor of Medicine for his thesis work on developmental changes in the brain circuitry in epilepsy. Then he went to Boston for a postdoctoral research fellowship working on mechanisms of brain development. And in 2006, he came to Texas Children's Hospital for his pediatric neurology residency. During his residency, he also encountered his first boy, a patient with MECP2 duplication syndrome, and this kindled his interest in MECP2-related disorders. In 2011, he joined the Faculty of Pediatric Neurology at Baylor Texas Children's and started to work on Gait analysis in a mouse model of MECP2 duplication syndrome. And then, more recently, in the beginning of 2014, he joined the Bluebird Circle Rett Center under the direction of Dr. Dan Glaze and sees children and women with Rett syndrome as well as patients with MECP2 duplication syndrome. Here, he was awarded the Bluebird Circle Career Development Award for his work on gait analysis in patients with Rett syndrome and related disorders. And Dr. Suter has published several papers, amongst one of them, MECP2 mutations in people without Rett syndrome, which was published in the Journal of Autism and Developmental Disorders in 2014. We're so grateful for your talk today and your presentation on movement disorders in Rett syndrome. This is a very well-attended webinar today. It's a very important issue for many of our girls and women, and I'd like to turn the screen over to you now so that we can get to all of your content within the hour allotted for our talk today. Thank you, Dr. Suter.
You're very welcome. Thank you, Paige, for your kind introduction. It is truly an honor to be able to speak at this marvelous Congress. And I would like to talk today about some movement disorders that typically occur in Rett syndrome. As you all know, Rett syndrome is a progressive neurodevelopmental disorder with a wide spectrum of behavioral and motor abnormalities. As had been found out in 2000, it has a genetic basis with mutations of the transcriptional regulator gene being MECP2 being responsible for it. However, it is not the genetic basis alone that makes for a clinical diagnosis. Key features in Rett syndrome are really motor problems. They include stereotyped hand movements, gait disturbance, and dystonia, and we'll talk about these in further detail today. In these key motor features you can see here are part of the main criteria to clinically diagnose Rett syndrome. I've listed down here the Rett diagnostic criteria of 2010, and you can see that of the 4 main criteria, actually 2 of them are concerning movement disorders, one with gait abnormalities and one with a stereotypic hand movements such as hand wringing, squeezing, clapping, tapping, and others. And importantly, further movement disorders are also amongst the supportive criteria for a diagnosis of atypical Rett syndrome. So what are the key movement disorders that occur in Rett syndrome? Well, an early study from the 1990s here out of Baylor actually analyzed in a population of about 30 girls with Rett syndrome what the common movement disorders were, and they found that all girls had the stereotyped hand movements and the gait disturbance, therefore not surprisingly showing up in the main criteria. But very common were also bruxism, which is really teeth grinding, and oculogyric crisis, which are little episodes of forced eye deviation, as well as dystonia and Parkinsonism, and I'll come back to these terms later on. What they found is that other movement disorders, however, occur very rarely, such as myoclonus, which is little jerks, or choreoathetosis, which is ringing like writhing movements. And here's the table that summarizes their finding, where you can see that in 100% of the girls analyzed, there were the gait problems and the stereotyped movements, but the teeth grinding and the eye movements and the dystonia were still occurring in way over half of the girls. In that paper, they also found that the movement disorders changed over time, in that with disease progression, as the girls get older and come into their adult age, their movements change. They become what we call more bradykinetic. That is, they move slower, take shorter steps, become overall somewhat more rigid, and also have less variation in their facial expression, something we call hypomimia. A second study much later on, in 2008, from Jenny Downs out of Australia. Jenny, by the way, you will hear a lot more during this week. She, I believe, has 3 talks, one talk on Tuesday on scoliosis and a talk on Wednesday on gross motor skills, where she surely will go into more detail of on this. She looked at the gross motor profile of a few more girls and women with Rett syndrome out of the Australian Rett database, and with a more refined data analysis, and she was able to dissect out that there are certain motor skills that sort of go together and ultimately form 2 groups. There is a group of general gross motor skills, and I'll come to that in a second, and there's a group of more complex gross motor skills. And by then we, obviously in 2008, we also had a molecular diagnosis, so she found a correlation with genotype. So she had 99 subjects from the Australian Rett syndrome database, and like the older study, the study was performed with video-based assessment complemented by clinical questionnaires. And here is a key table from that paper where you can see the general skills on top, and these are simply sitting in various positions with and without support, transfer, standing for a certain degree of time, then walking and turning, whilst the complex skills that cluster together were transferring from one position to another, so transfer from floor to standing, for instance, or bending over to pick up objects. And the importance of that is that they were able to demonstrate that, yes, there was a decline, mild to moderate decline, with age in the general skills, so the sitting, the standing, the walking, if the girls achieved that before, but they were only seeing a trend of a decline in the complex skills, in the more planned, so to say, activity. And the importance, what I want to kind of bring home here, is that multiple prior studies had stated that there was sort of a definite, clear decline to be expected with age, and this still holds true, but maybe not to the extent that we first thought in the 90s. As pertains to the molecular genetics, she was able to chisel out a relationship to some common mutations, in that three of the common mutations tended to have a milder motor phenotype, and some others, on the contrary, did really have more motor problems. However, please note that these are just correlations that we are able to derive in research over a large group, and this does not mean that if your child or acquaintance has Rett syndrome that we would be able to predict an outcome based on a certain mutation in this single case. There is still a broad spectrum of phenotypes or of presentation possible for each mutation. It is noteworthy, however, that in a very recent study with now still a much larger number of participants, based on the natural history study that went on for the past 10 years or so here in the US, they found that walking paralleled the overall clinical severity the closest. And they were again able to dissect out that these certain mutations tended to do better with respect to motor, ambulation, hand use, independent sitting, and a later onset of stereotypies. And they had over 1,000 participants that they analyzed in this natural history study. So I would like to come now back to the terms and just define a few of the terms that you might encounter in doctor visits, in literature that you look at. And these are motor problems that are really of great importance in Rett syndrome. So first I want to talk about ataxia/balance. Ataxia really describes a lack of muscle control and coordination during voluntary movements, such as walking or picking up an object. And importantly, it is often the earliest motor problem that shows up in Rett. So when the girls walk, they kind of then develop a broader stance, that means a broader base, and they develop an unbalanced way of walking. And this ataxia may cause fear of falling as it gets unsteady, and this further restricts their own efforts to walk. And this is very important to keep in mind, and I'll come back to that later on, to try to work with a girl, with a woman, through this fear of falling, because keeping mobility is so important for this population. Currently, there is no treatment for this type of ataxia per se, so we cannot treat it causally, but to some extent it can be overcome by guidance strategies such as sensory feedback and support with walking. When it becomes more severe, use of a walker may become necessary in order to continue the mobility in the child. A second term that is often used and very pertinent to Rett is motor apraxia, or better dyspraxia, and that refers to inability to plan and execute a movement sequence. So it really affects the control sequence that you actively plan of how and when and which muscles to move, this dyspraxia. It strongly affects walking or reaching for objects, but even can influence other parts of movement, such as eye movements, or when it comes to phonation speech, the speech can be off. And important to note that the more active thinking versus automatic action is involved in movement, like moving on command to reach something, the more difficult it becomes for the person to initiate and execute that movement sequence. So automatic action or practice action might still work very well, whilst spontaneous, active, on-command movements may be much more frustrating to that person. So examples are over or under reaching for a toy, stepping in circles rather than walking towards a goal, overshooting when reaching, or knocking objects over. And it often manifests in a very intense preparatory activity in the girl with Rett syndrome, where she rocks back and forth, wrings her hands, stares intently, maybe even hyperventilates before she attempts to, actually act out the movement. And there again, in dyspraxia, guidance strategies are the way to approach treatment to make the movements possible. Now let's come to an extremely important movement disorder that is less linked to the cognitive abilities, and that is dystonia. You will hear this over and over again. Dystonia is an alteration in muscle tone, therefore dystonia, in a fashion that produces spasms. These very often are prolonged, but at times can also be brief and jerk-like, and that is important to keep in mind because sometimes they may appear almost like seizure-like movements. Often they lead to unnatural appearing body positions, and the person might even get stuck, if it is a prolonged dystonia, in certain poses. Dystonia commonly occurs in many different medical syndromes, not just Rett syndrome, and may have multiple etiologies. And the importance of that point is that very often when we try to approach treatment of dystonia, we need to do several treatment approaches and combine them together. For instance, use multiple medications, physical therapy, and use of bracing or orthoses. So important to keep in mind for your child is what else can really look like dystonia but would not be treated in the same way. Well, one thing is spasticity, which is not truly a movement disorder, but it is a more permanent increase in tone, in an overreactivity in tone. It is what we commonly test when we, as a neurologist, test reflexes. We observe an increase in reflexes that can point to spasticity. This permanent increase, just like dystonia, however, can lead to contractures at joints and appear like dystonic postures. And there it is important to note that some increased tone spasticity can be very supportive, for instance, in gait, in walking, especially if the child is otherwise somewhat hypotonic, means, well, floppy or has reduced tone. It is supportive for any activity where the child needs to be upright and sort of work against gravity, so you don't want to over-treat that either. Then at times, as I mentioned earlier, dystonic, especially brief dystonic episodes can mimic seizures. Often when it's focal dystonia occurring in the face can be very confusing. These oculogyric dystonia where the eyes are forced in a certain position, or limb dystonia at the feet can be really difficult to tell apart from seizures. And then there, sort of as an outlier, occasionally posturing with, in the young children and infants with gastrointestinal reflux can also result in positions that can be mistaken as dystonia. And here I've just listed a couple of focal dystonia appearances, and you can see that these dystonic episodes can lead to sort of crunching up of the face or putting the feet into unnatural appearing positions. And if these occur repetitively, you can imagine that maybe this mistakenly makes one think of seizure-like episodes. So whom do you really talk to and who treats these movement disorders? Well, it is super important to get evaluated not just by a single person, but really by a multidisciplinary team that all can witness these movement disorders. So amongst them, obviously, preferably pediatric neurologist with experience in movement disorders as they occur in Rett syndrome. But the children should certainly also see a physical medicine specialist for the tone issues, and physical therapy is extremely important. Sometimes they need to see an orthopedic surgeon, for instance, if they have developed severe scoliosis. And they should also see a GI specialist, especially if there are concerns for reflux as a cause of movements in this regard, but of course also for nutritional, etc. reasons. The child may need further testing to really chisel out what is at the basis of these movement disorders. For instance, they might need a video EEG to rule out that they are not seizures, or other testing procedures to really make sure these are movement disorders. And the first step could be for the parents to record a video of these events, let's say on a cell phone nowadays. That's easy to bring to the office visit so that the specialist can have a look at the actual episodes rather than rely on a description on it alone. I want to come back to dystonia, however, because this is a field where, as opposed to the two prior entities, the ataxia and the apraxia that we talked about, here for dystonia we do have treatments available, and they can work very well. And sometimes, however, you need to combine several treatments, as I talked about before. And here are some of the common medications that are typically used in dystonia. You might have heard of them already, or you might in the future. So medications that are commonly being used for treatment of dystonia are Klonopin and benzodiazepine, or baclofen, or medication that that is trihexyphenidyl, Artane with trade name. And these are medications that each of them have, of course, their own benefits and side effects, and careful titration is of the utmost importance. And for more severe cases, there are also further medications such as tetrabenazine, which need to be given under very, very close monitoring for the side effects. But I want to throw them out here because I want to sort of portray a hopeful picture that for dystonia, at least, there are several medications available to treat this movement disorder. Finally, I want to talk about gait a little bit because it is so important in these girls. So usually we say roughly around half to over half of the girls do develop independent walking. And the pattern of gait, however, is very variable but has some common features. So Andreas Rett, in his original description from the 60s, actually described short steps, sometimes a shuffling gait, sort of like older person with Parkinson's taking very short steps, but broad-based and with wide swaying movements of the trunk, which is not like Parkinson's patients. And over time, the girls very often develop tiptoeing in almost 40%. And then there is this peculiar feature where they actually develop a tendency to push backwards, and if they were not supported, would fall backwards. We call that retropulsion. In the later stages, the gait pattern changes, and especially the initiation of walking becomes very hesitating, and this is really where they need ample encouragement and guidance to keep them mobile. What other interventions do we have in general for motor problems? So we talked about the medications for dystonia mostly, but then there are other not less important approaches, and amongst them, of course, physical therapy, occupational therapy, the use of bracing and casting and AFOs to maintain range of motion. In extreme cases, maybe surgery for heel cord release or to fix a scoliosis. And if the movement disorder just concerns a very defined muscle group, there is also the possibility to do botulinum toxin injections into targeted defined muscle groups. You wouldn't do that for general dystonia, but if it is, for instance, dystonia targeted at the ankle, you might approach that with botulinum toxin injections. And then really reserved for very severe cases that seldomly occur, there's deep brain stimulation for these movement disorders. And I just wanted to briefly explain what bracing and AFOs and so on look like and what they are. So this is a picture of one example of an AFO, an ankle-foot orthosis, that many girls with Rett syndrome wear inside their boots. You put it on and then still wear a shoe over it, and you can walk with it. So they're very lightweight, sort of plastic braces that help to hold the foot flat and work against developing of contractures in the heel cords. And so they maintain really the range of motion that is so essential. And they're really most often used in conjunction with physical therapy. So it is really of very big importance to combine such treatments together with physical therapy and medical treatment. Very occasionally I have a patient where they only wear an AFO. I don't think that is enough. It really needs to be combined with active therapy. If we see the patient sort of a little bit later on and the heel cords are already too tight and cannot be brought to a flat position, there's still plenty of options. One common one is serial casting, where you kind of serially very slowly stretch out the heel tendon until full range of motion is achieved again. And in more severe cases, there is also a surgical approach called heel cord release. One general comment about these intervention and therapy, so as I said, back in the 90s, the attitude was maybe a little bit more bleak, where we accepted that, you know, there would be a decline with motor abilities, and that there is often, and that is true, there is need for repeat, even surgical interventions over time for these movement disorders, and for instance to keep the heel cords flexible or scoliosis controlled. And then even despite these interventions, often there is a further decline in the motor skills, especially with walking in the later stages of the disease. However, there are several reports out there, and I just want to point out one by Larson and Engerstrom out of 2001, where they report that with really persistent and innovative intensive therapies, there is absolutely a chance for improvement. They reported, for instance, in their case series on a woman that had classic Rett syndrome who had been confined for a wheelchair for several years, I think even 15 years or so, who got persistent physical therapy with innovative sort of cluing in strategies and was retrained to achieve standing at the age of 36, and eventually even walked and was able to transition from the floor to a chair by age 40. And so she was really, apart from the general benefit for her health, she also was so happy and joyful that she was now able to do all of these abilities independently again. So that is a very hopeful, albeit single report, right? But another patient, or actually several patients they reported on, were with innovative physical therapy strategies where they clued into a movement and recalled prior movement memory. They were able to guide the child to maintain skills for a really long time, for instance, transitioning from the floor or walking when the therapy was initiated at the first signs of a motor decline. So it is really important to not give up, be very mindful of a decline, and start very intensive therapy at that point. Lastly, I just very briefly want to touch upon clinical and basic science research that is being done in motor disorders. So people are actually studying this intently. In the clinical research domain, they're using methods such as questionnaires, like the motor behavioral assay or similar ones used in the natural history study, video assessment, activity trackers like Jenny Downs used in her studies, and then also there are some studies that use a professional gait lab. Here at Baylor, we, for instance, currently have an ongoing study to examine subcomponents of gait problems in a professional gait lab. And then there is basic science, where, you know, we use mouse models of the disease where the mice have genes altered in a fashion like the human disease, and these mice are actually alive and walking and running, and they're being imaged for the purpose of looking at their brain activity using novel approaches that really only have become available over the last 10 years or so with fluorescent dyes and microscopy. And the researchers are hoping to learn something about the fundamental changes in the brain circuits of these mice in the hope to find targets for therapy. And this would be an example of such a mouse running on a running wheel, and an analysis of its paw movements. And what you see here on the right are little neurons. These little blobs in green are neurons, and they, over the time that the mouse runs, on a video that I don't have in this presentation right now, these light up, and you can look at the concerted activity of, you know, the neurons and kind of analyze this activity. And then the pendant to that is, for instance, a gait study in a professional gait lab. And this is Erin Knight, one of our senior research assistants in the U of H gait lab, and where we have a gait study for girls with Rett syndrome ongoing. And these are some selected references that I sort of wanted to point out, and that's it. I want to thank you very, very much, first and foremost, to the families and children that are so devoted to their children and finding a treatment for their children. And then, of course, for the mentorship of Dan Glaze, Huda Zoghbi, and Jeff Newell, and also these fabulous institutions supporting the Rett clinics and research, rettsyndrome.org and the Bluebird Circle Rett Center. And this is sort of a prior photo of the Bluebird Circle and Rett Center. Unfortunately, Dr. Jeff Newell has left us since, and Dr. Ramaki too, but then there is a relatively new member, that's me. All right, thank you very much.
Thank you, Dr. Suter. That was a phenomenal presentation, and we've had a number of questions that have come in. Do you have a little bit of time?
Absolutely, yes. Mm-hmm.
Great. So we'll take some questions for about 10 minutes, and if we don't get to all of them, I know you said you'll work with me to develop a question and answer document that we'll be able to send to everybody that registered today.
Absolutely, yes.
Yeah, I don't know if you realized quite the popularity of your topic. We maxed out on attendance, so we have a number of people who were hoping to catch your talk who weren't able to join today. So I'm really glad that we recorded it and we'll be able to hear. Yeah,
very good.
That's good news for our newest member of the Baylor team.
Thank you.
Yeah, okay. So let me share with you the first question that came in. I think it's important to share in order that people wrote in. We had one of our attendees ask about some treatments found to help with severe tremors, and if there are any that you know to have been effective for severe tremors.
For really severe tremors, there are certainly medications for tremors that probably the person such as is aware of, such as beta blockers, clonazepam, and these tend to be more medications that help with milder tremors. And now I'm not really sure how severe the tremors are, but there are studies out there being conducted on what I mentioned before for the movement disorders, on deep brain stimulation to help with severe motor problems. However, these are still very, very seldomly performed and usually based on clinical studies, so it is not a routine intervention. Does that partly answer the question?
Yeah, thank you. We did have another parent ask about deep brain stimulation.
Okay.
And she describes that her 9-year-old daughter developed myoclonic during her early.
Sorry?
She describes that her 19-year-old daughter developed extreme myoclonics during her early teens, and they've had difficulty gaining much control through any medications. So who would she approach to? Who in the country is doing this? Yeah,
and she had a question about the applicability of the brain stimulation as well.
Yes.
So deep brain stimulation, as far as I'm aware of, really first and foremost is for movement disorders is more standard for the dystonia, which is the framework that I portrayed here, and less so for these other disorders. Some deep brain stimulation certainly can help with tremors. For myoclonus, I'm not so aware as a mode of choice. Just for the general audience to explain deep brain stimulation, it is a very intricate neurosurgical procedures where basically stimulating electrodes are being implanted and targeted to very tiny centers in the brain that we think are involved in the generation of these movement disorders. In the case of dystonia, a region called the globus pallidus internus, but it is really at the end of the spectrum of movement disorders because it is an involved neurosurgical procedure and therefore, of course, carries the risks of neurosurgical procedures, including just surgical complications, infections, blood loss, what have you, and then in addition, specific to this neurosurgical procedure, the success really depends on how tightly you can target the electrodes into the brain region that is responsible for the generation of dystonia, and that can be extremely tricky. So to come back to the question of severe myoclonus, apart from medication strategies, I am less aware of alternate means to control severe myoclonus. Obviously, some bracing can help with sudden movements, but it doesn't go to the origin of the myoclonus. All right. Hello.
Thank you. And if anyone in the audience has additional questions on that topic, go ahead and write them in. And if we don't get them answered today live, we will answer them afterwards in a question and answer document. So Dr. Suter, another question is a question of why do our children develop dystonia later in life? Why is this a progressive symptom? And if something like retropulsion is new, can that be helped with some medications that were mentioned, maybe that someone has tried in the past, but their child now has new symptoms? Should they try some of these medications again?
Yeah, absolutely. I think as the picture of these movement disorders change over time, and what I mean by movement disorders, let's say the gait change, the type of the approach to walking changes over time, that should be really very closely monitored. You can certainly imagine that this retropulsion could be in part due to dystonic movements that sort of intervene with the walking, though the retropulsion is not necessarily due to dystonia alone, right? But if there is a dystonic component where, upon sensory feedback with walking, the child locks into a certain position, then it might be very worthwhile to reassess that and try therapy for dystonia. Otherwise, for the retropulsion specifically, at times, innovative targeted sensory feedback strategies and guidance can partly overcome this retropulsion. Certainly not completely. Mm-hmm. Hello? Hello? I think I may have lost you.
Dr. Suter? Hi there.
Yeah.
Dr. Suter?
Now I can hear you.
Okay.
Can you hear me?
We have you. Yes, now we can. Yeah,
Okay,
I think the
perfect.
feed from your webcam might have been slowing down the audio. So if you wouldn't mind,
Sorry.
you can. Mm-hmm. Oh no, it was wonderful for everyone to get to meet you. And
all right.
if you wouldn't mind, go ahead and turn your webcam off. Then we should be fine with the audio.
Okay, perfect. Yep.
Great. No problem now. Good. No feedback. Hopefully that cleared up for our audience as well. I have a couple of other questions if you still have some time.
Absolutely.
Okay. Well, first, someone asked if you could put up the slide with the recommended references so that people could take a look at that while we answer some of your other questions.
Okay.
Just leave that hanging for a
There we
moment.
go.
Great, thank you. Okay, So somebody asked if you have discovered the anatomic reason for weakness in legs. Is it a problem in this spastic paraparesis? Do you know? Is it what's the etiology of it?
So that is still, we in general we know roughly which neuroanatomical parts are involved in either spasticity, which is not due to upper motor neuron and pyramidal tract lesions, versus dystonia, which is much more due to a feedback loop between the cerebellum, the basal ganglia, the motor cortex, so the brain proper. So we know which neuroanatomical parts in general appear to be involved. However, it is, like always with the brain, we have these different parts in our brain, and they're there to talk to each other, and we don't, they're fluidly talking to each other, and we still need to figure out how this this talk between the different regions is happening in real time while these motor disorders are being generated. And it's only recently that we are even coming close to studying this in the humans, functional MRI studies, and in the mice, as I had showed you, with novel approaches with new types of microscopy, two-photon microscopy and novel calcium imaging, where we can really look at the different brain regions, how they talk to each other, and within the brain regions, how the different neurons talk. So we've sort of entered a new era where we don't look neuropathologically only at, oh, there has been a lesion to one brain region and that is the cause of dystonia or spasticity per se, even though that can be the case in extreme cases such as, a stroke where that wipes out a part of the defined part of the brain. But here we're more talking about a completely different type of disorder where all these different centers are fluidly involved. You would not, when you look at it under a conventional microscope, you would not necessarily see pathology only in one well-defined region. It is sort of more this crosstalk that is being affected.
Okay, thank you. And we look forward to you discovering some further answers to that question.
Thank you.
That lead to interventions. We've had a couple of questions come in about the use of adapted equipment in the therapeutic setting and how successful that is. I've had families describe, I'm going to kind of put in a couple of questions into one, a couple of symptoms. So for the child who has a fear of walking, what sort of devices might help her overcome that fear the most in a therapeutic setting, which is not just a gait trainer, but is there something else? And have you had any experiences with any of the body suits or walking motion devices like the InnoWalk or anything from Theratogs to a Spio vest to suit to an exoskeleton? There's a whole spectrum of devices now on the market. And have you had experience with any of those particularly suited? And I have these questions coming in from parents of very young children, as well as parents of children who used to be very good walkers and maybe are not so good anymore.
So personally, I'm obviously a pediatric neurologist. I'm not the physical therapist or the physical medicine doctor that directly works with these devices, but from the patients that I do see, I glean a good deal of feedback, and I've had very favorable feedback actually for recently, and this really has come about over the last year or so, with these devices that you mentioned last, like the body suits, that these can help, especially in children that maybe are on on a path where they seem to have a gradual decline to halt that decline somewhat. Yeah. The other component to halt the decline, and that is not always feasible because therapies are so hard to come by in general these days, is, and maybe therefore more of the burden unfortunately is again lying with the families, is to try to figure out if the child learned to walk before and to transition from the floor, to try to kind of remember these abilities, in what circumstances they occurred, and to recreate these circumstances. So what I want to say is that what I've heard is that if they're being asked in a therapy session that is kind of not artificial necessary, but very different from their natural home environment, they might not perform as well as if the home environment is being recreated in that prior situation where they were able to transition from the floor to sitting, or from sitting to standing, or taking a targeted walk towards an object is recreated. This kind of goes hand in hand with this description that the dyspraxia is very closely linked to how automatic movements are, and so very often we find that even with in a fairly declined phase, that the children still have a memory of sort of an automatic memory of movement, and if they're clued into that motor memory, they're able to still perform these movements. Now, that obviously doesn't help that much if you try to bring this out in a completely novel environment, and it takes a lot of therapy and patience. But it is something to work on with a child, rather than saying she cannot do this per se, is to remember what she could do and try to remember the circumstances in which she was able to do it.
Okay, thank you. And as you reminded everybody earlier, we do have some additional talks this week coming from Jenny Downs in Australia. Been working with Rett syndrome for a very long time. Her talk on scoliosis will also include recovery of motor skills that appear to be lost after an intervention like a surgery, and with some very encouraging news. So if you'd like to schedule for that webinar, you'll get some additional information there. And she's also talking about gross motor therapeutic interventions to incorporate into our homes and our days at school and at home. So I encourage you to register for those webinars. If we can come back into your area of medication interventions, I have some questions from families about the possibility that medications are causing motor difficulties. So can you comment on how do we discover if maybe a seizure medication, Keppra, Lamotrigine, if a new medication is causing a disorder and a movement disorder, and when do you say that's better, it's helping with other symptoms like seizures or breathing? And how do you,
How do you go about that? Yeah, and that is a very tricky and key question, obviously, because especially in the more progressed phase, there will be both, right? There will be seizures and there will be movement disorders, dystonia, and so luckily, maybe first off, some medications are actually helpful for both, so one can focus on maximizing therapies with the help of these medications that treat both seizures and dystonia specifically. But yep, there are definitely medications that can cause, for instance, tardive dyskinesias, medications typically that are being used for more mood disorders or similar neuropsychiatric issues, which are not uncommon either. And it is really a fine line to be to be extremely, to not over-treat with multiple agents, throwing sort of multiple agents at the child at the same time, but going in a very rigorous step-by-step fashion, such that if these side effects occur, that one notices them relatively shortly after introduction of the medication. And if that occurs, to maybe backing down on the most likely culprit and seeing whether that has is successful in controlling this side effect. And then luckily for seizures and for dystonia, we do have quite a few medications out there, so that you mentioned, for instance, Keppra. Keppra is not the only medication, albeit a very, very commonly used, at least in the initial phases of seizure management. But there are about 20 different seizure medications by now that can be used. Now, not all might be appropriate, but certainly when these problems occur, I think the family should not hesitate to discuss that with their neurologist and see whether it is not worthwhile to introduce it back down on the most likely culprit and introduce a different medication instead. It is not an overnight thing, for sure, because backing down is a certain skill as well. And also, even if you are very rigorous and only introduce one medication after another instead of together, some side effects develop later on while already several medications are on board. So it will remain a little bit of a trial and error approach. But the hopeful news is that in most cases one can get a grip of these unwanted side effects. All right?
Thank you. Thank you. I think the important message there is to keep open the dialogue with your treating physicians and document and monitor.
Yeah, documentation is very important. So leading sort of a diary, not only a seizure diary or video documenting the movements, but maybe also being really mindful when a new medication is being introduced, because at times there is even a crosstalk between medications, and so it's very important to document the effect, especially in the initial, let's say, week or two after a medication is being introduced.
Okay, I have I'm trying to catch everybody's questions, and so I'm taking some of them that are on a similar topic and clustering them together, because we will have to conclude in a few minutes.
Yeah.
So I'm going to take a few questions and put them into one, Dr. Suter.
Yeah.
In the area of progression of motor impairment, whether it's slowing down in mobility, loss of hand use, or tremors, do you have a sense of how quickly these can progress? With regression, we know it can be very rapid or it can be very slow in the early years. With motor difficulties, do you see, I think what parents are trying to ask is, how long do you continue to work with your physical therapist on range of motion and stretching and, kind of hands-on therapies versus making the decision that it's time for surgery or something more advanced or a medication? And how much time do you have before you can't regain function? Can you comment on that?
Yeah, absolutely. So I think a good answer to that would be that it is really important to start the various avenues of therapy and assessment, even through specialists that we have very early on, when you notice decline. In sort of answering the whole question in one, certainly typically there is the early phase of regression, and then there is, at least in a typical scenario, some stabilization, maybe even a gain of skills, and then towards late adolescent, early adulthood, there's another phase where maybe some skills are much more slowly, albeit lost. And in that phase, it's really very important to be mindful, once that sets in, to be very aggressive in treatment. And I think to answer the question of how to approach that and how long to work with a therapist, in my mind, it can never be long enough, because because of what I showed in my talk, or at least listed in my talk, is that even very late on, some skills with very intensive physical therapy can be brought back. Maybe not in every child, but still there's the potential for improvement even in that late phase of decline of motor skills. And so even if one was at a point where one chooses a more extreme approach as surgery, this patient has had several surgeries, even long before, at the heel cord specifically, to stabilize gait, long before she regained skills. So the question for a surgical approach, I think, is mostly based on the real physical characteristics of the frozen joint, the shortened tendons, and whether in the scoliosis, and whether these really become so fixed and severe that with all the physical therapy and stretching in the world, you're not able to even come close to a normal range of motion. Then it is at least, the time to get assessed by an orthopedic surgeon whether such an intervention is warranted. But that doesn't necessarily mean that after the surgery to give up on the physical therapy, nor on the supportive devices, which are the ankle-foot orthoses, the braces, the body suits that help maintain a functional state. Does that answer partly the question?
I think so, and I think it's time for us to conclude at this point. We're at the top of the hour. I do have a number of questions that have been submitted, and so Dr. Suter will get all of the questions over to you in a text format document so that you can review and make sure that we've answered them comprehensively, because I know that you're very interested in making sure that everyone's questions are answered, and I hope that you'll join us again for a part 2. We've had such great interest in this talk, and I think it is a very important area. We wish you great success in both your clinical research and your clinical practice, and we are so grateful that you're with us.
You're very welcome, and thank you very much.
Okay. Well, thank you. And to our attendees today, I hope you found the session extremely helpful. And I want to thank you for your time, and thank Dr. Suter. I want to thank our sponsors, Tobii, Dynafox, and Ameripride, for being able to bring these sessions to you at no charge, and we hope to continue to do more sessions like these. So please, if you would take a chance to answer the webinar survey when it comes to you, so we can fine-tune how we can continue to bring education to all of you. And on that note, we will conclude our presentation today, and we hope to see you at one of our many webinars that will continue this week and in the coming weeks ahead. Thank you so much. Have a wonderful afternoon. Bye-bye.